You know, just thinking about how our eyes, these two separate structures, manage to work together so seamlessly, thousands of times a day, to give us a single, clear picture of the world. It's really incredible when you stop to consider it.
It really is.
But what happens when that perfect coordination, that delicate synchronization, gets disrupted?
Well, what's fascinating here is that even a subtle disruption in that system can lead to profound and often, very disorienting visual problems.
Hmm.
We're talking about situations where the eyes don't just see double, but the amount of the double vision or the eye misalignment actually changes depending on where you're trying to look.
Exactly. And that brings us right to the heart of today's deep dive. We're pulling from a classic, dense medical source, Chapter 22 of Parson's Diseases of the Eye, which focuses specifically on what are called incomitant squints, with a strong emphasis on paralytic squint.
Right. And our mission today isn't just a quick summary.
Mm.
This deep dive is truly about getting into the weeds, exploring every concept, every mechanism, every diagnostic nuance laid out in this material.
Yeah.
It's about building a level of understanding that approaches mastery, the kind that, elite professionals in this field rely on.
So consider us your guides as we navigate this complex landscape. We're going to unpack the fundamental definitions, explore the surprising variety of things that can cause these issues, delve into the signs and symptoms in detail, dissect how clinicians diagnose them, and look at some specific types and related conditions.
Okay, so at the highest level, the source introduces the concept of incomitant squints. The defining characteristic is that the magnitude of the eye deviation isn't constant. It varies depending on the direction of gaze.
Right, and that immediately sets them apart from comitant squints, where the deviation stays pretty much the same no matter where you look.
Exactly.
The text points out that while paralytic squint, meaning muscle paralysis, is the classic example, the term incomitant also includes restrictive squints, where movement is mechanically blocked, and some other syndromes we'll get into later.
And a crucial point the source makes up front is where the problem lies in the nervous system. It focuses heavily on lesions at the lower neuron level.
Lower neuron level, okay.
Think of this as the final pathway from the brain to the muscle. The nuclei in the brain stem where the nerve starts, the cranial nerve itself that's third, fourth, or syncytial, or the muscle fibers.
So it's damage at the very end of the control system. And these lower neuron issues are precisely what mess up the eye's relative coordination and cause that hallmark symptom, binocular diplopia, or seeing double when both eyes are open.
Right. Contrast that, as the source does briefly, with supranuclear lesions problems higher up in the brain's control centers. Those typically cause conjugate gaze issues, where both eyes move abnormally but stay aligned with each other.
Ah, okay.
Because they maintain that relative alignment, they don't cause diplopia. The text says those are covered elsewhere, so we won't focus on them today.
Okay, so we're focusing on damage to that final command path. Let's start with the main category. Paralytic strabismus. The source gives us a clear definition. It's simply a squint that happens because one or more of the extraocular muscles that move the eye are paralyzed or, significantly weakened.
And the potential causes for this paralysis, the etiology as the source terms it, are incredibly diverse. The text categorizes them, listing congenital problems, trauma, various types of infections, neoplastic causes like
Tumors, right.
vascular issues affecting blood supply, and inflammatory disorders, a whole range.
So it could be something you're born with, an injury, or a complication of a systemic disease affecting different parts of the body.
Exactly. And the pathophysiology, how the damage occurs at different points along that lower neuron pathway, is detailed. First, you can have lesions affecting the nuclei of the cranial nerves in the brainstem.
Okay, the starting point. What kind of things affect the nuclei?
The source mentions things like small bleeds or clots, often linked to conditions like arteriosclerosis or diabetes. Demyelinating diseases like multiple sclerosis can affect the nuclei,
MS. Yeah.
as can infections of the central nervous system, specific toxins like botulism, or nutritional deficiencies like thiamine deficiency.
Right.
Historically, the text notes syphilis was a common cause too.
Wow. And these nuclear lesions are often connected to broader systemic or neurological conditions, right? Sort of highlighting how these eye problems can be a window into what's happening elsewhere.
Absolutely, it's a crucial connection. Then you have damage to the nerves themselves, cranial nerves, third, four, and six, as they travel from the brainstem through these, complex bony cavities and spaces to reach the eye muscles.
So they can get compressed or damaged along the way.
Exactly. Think infections spreading into the meninges surrounding the brain and spinal cord, or within spaces like the cavernous sinus or the orbit behind the eye. Tumors or aneurysms pressing on the nerves are significant causes. Skull base fractures can sever or crush them.
And here's where it gets really interesting for clinical presentation. The source points out that secondary invasion by malignant nasopharyngeal tumors, cancers in the back of the nose-throat area, can cause cranial nerve palsies as an early symptom as the tumor spreads upwards towards the skull base.
That's a really important clinical pearl, an early sign of something potentially serious.
It raises an important question, one the source addresses. Why is the sixth nerve, the one controlling the lateral rectus muscle moving the eye outwards, so frequently affected by generalized raised intracranial pressure?
Good question.
The text explains that it's often not a sign that the problem is at the sixth nerve nucleus itself, but rather that the nerve is vulnerable elsewhere.
It has a long course, right?
It does, a very long intracranial course.
So it can be stretched or compressed as it crosses over a bony ridge, the petrous bone, or caught between arteries.
So the pressure itself makes it susceptible due to its anatomy. That makes sense. Fascinating that something happening inside the skull can show up as a specific eye movement problem. The source also mentions spinal anesthesia, sometimes causing lateral rectus palsy.
Really? How?
Likely due to traction on the nerve or pressure changes. It says it can have rapid onset but often slow recovery. And ophthalmoplegic migraine is noted to sometimes involve the third nerve, possibly due to swelling or compression of arteries that the nerve travels alongside.
Okay. And finally, the problems can be directly at the muscle level. Orbital diseases or injuries are common culprits.
Right.
The source specifically highlights traumatic or inflammatory damage to the trochlea that's a pulley-like structure that the superior oblique muscle tendon passes through.
The pulley.
As a frequent cause of superior oblique weakness.
Okay. What about other muscle issues?
Other muscle-specific issues include myositis, which is inflammation of the muscle itself, dysthyroid eye disease, where thyroid problems affect the eye muscles.
Like Graves' disease.
Exactly. Also, hereditary muscle disorders, and acquired conditions like myasthenia gravis, which is an autoimmune disease affecting nerve-muscle communication.
So, to really master this topic, you need to appreciate that the palsy can originate at any point along this pathway. The nucleus, the nerve, or the muscle itself, each with its own set of potential causes.
Absolutely. It's not just one thing. You have to think through the whole pathway.
Right. It's not just one thing. Now, how does this manifest for the patient? What signs and symptoms would an elite professional be looking for? The source provides a clear list. Squint, limitation of ocular movements, diplopia, false orientation, an abnormal position of the head, and vertigo.
Let's take these one by one. The squint itself is key. The source emphasizes that its magnitude isn't fixed. It's more noticeable, the deviation is larger, when the patient is trying to look in the direction where the paralyzed muscle is supposed to be most active.
Okay, so picture a right lateral rectus palsy. That muscle pulls the eye outwards. If it's weak, the eye drifts inwards. Esotropia. And that inwards deviation gets worse when the patient tries to look right, because that's when the weakened muscle is called into action most strongly.
Precisely. And the direction of the squint, the source explains, is typically opposite the action of the paralyzed muscle. This happens because the opposing muscle on that same eye, the antagonist, is unopposed and pulls the eye towards itself.
Makes sense. Limitation of ocular movements is pretty straightforward. Then the eye just can't move fully in the direction the weak muscle is supposed to pull it.
Right. Although the source cautions that in mild weakness, what they call paresis, this might be subtle and require careful testing. The eye might look perfectly straight when the weak muscle isn't needed much.
So you might miss it on a quick glance.
You could. You can do a rough check by having the patient follow your finger. But for precise measurement, the source describes plotting the field of fixation, essentially mapping out how far the eye can move in all directions, similar to visual field testing.
Okay.
The text even gives normal ranges, about 50 degrees down, 45 degrees otherwise.
They also mention charting the binocular field of single vision, the area where the patient doesn't see double, and the practical field, where they might achieve single vision using a compensatory head turn.
Now, here is a crucial concept, a real cornerstone for mastering the clinical exam, and it involves relative movements and deviations, particularly using the cover test.
A distinction between primary and secondary deviation. This is where it gets really interesting in terms of diagnosis, right?
Absolutely.
Yeah.
This is fundamental. The source instructs to perform the cover test in primary gaze, looking straight ahead, and in various other gaze positions. Primary deviation is measured when the normal eye is fixing on the target. The paralyzed eye deviates because its movement is limited.
Okay, so normal eye fixing, look at the deviating paralyzed eye. That's primary.
Correct.
Okay, so if I cover the good eye and make the weak eye look, that's when we see secondary deviation.
Precisely. When you cover the normal eye and force the affected eye to fixate, the brain has to send a stronger nerve signal, extra energy to the weakened muscle to get it to move towards the target.
Okay, more effort needed.
Right. And the source invokes Herring's law of equal innervation. This same amount of extra nervous energy is simultaneously sent to the corresponding yoke muscle in the other eye, the muscle that works together with the weakened muscle to move the eyes in that particular direction.
And because the normal eye isn't limited, it receives this excessive energy and overshoots the target behind the cover.
Exactly. That's the key mechanism. The source gives the classic example, a right lateral rectus palsy. If the normal left eye is fixing, the right eye is turned inwards. Primary deviation.
Got it.
But if you cover the left eye and ask the patient to fixate on something to the right with the paralytic right eye, the left eye, behind the cover, will deviate outwards much further than the right eye deviates inwards. That large deviation of the normal eye when the paralyzed eye fixes is the secondary deviation.
And the key diagnostic nugget here, the one you absolutely need for mastery, is that in a paralytic squint, the secondary deviation is always greater than the primary deviation.
Always greater.
The text contrasts this starkly with committant squints, where primary and secondary deviations are equal. This difference in magnitude is a direct consequence of Herring's law and the effort required by the weakened muscle.
Understanding why secondary deviation is larger, the brain overcompensating and sending too much energy, is fundamental to diagnosing these conditions.
Absolutely crucial. Okay, moving on. Diplopia, or double vision, is often the most bothersome symptom reported by patients.
Yeah, it's usually what brings them in.
Yeah.
And the source clarifies it's binocular diplopia, only happening when both eyes are open.
Right.
It occurs specifically when the patient is trying to look in the field of gaze where the affected muscle is supposed to be working.
And the text notes that the image from the squinting eye, the false image, is usually blurrier because it's not focused on the fovea, unlike the true image from the fixing eye.
Correct. And the distance between the true and false images is directly related to the angle of the eye deviation.
And the relative position of the false image is crucial for diagnosis too, isn't it? Homonymous versus heteronymous.
Yes, absolutely critical. If the right eye is turned inwards, esotropia, due to, say, a lateral rectus palsy, the image falls on the nasal part of the retina.
Okay, inside part of the retina.
The brain projects things from the nasal retina out to the side, temporally, so the image appears to the right of the true image.
So the right eye's image is seen on the right.
That's homonymous or uncrossed diplopia. The false image is seen on the same side as the deviating eye. The source clearly links this with esotropia.
Okay, and conversely, if the right eye is turned outwards, exotropia.
Then the image falls on the temporal retina, the outer part. The brain projects from the temporal retina inwards, nasally, so the image appears to the left of the true image.
So the right eye's image is seen on the left.
That's heteronymous or cross diplopia. The false image is on the opposite side of the deviating eye. This is linked to exotropia. Mastering this distinction and how it relates to the direction of deviation is essential for interpreting clinical tests.
Definitely need to keep that straight. Homonymous for esotropia, heteronymous for exotropia. Okay. False orientation or false projection is another fascinating symptom the source mentions.
Yeah, it's described as a necessary accompaniment of diplopia.
How does that work?
The text gives a great example. If you have a right lateral rectus palsy and cover the normal eye, then try to quickly point at something to the right. With the affected eye fixing, you'll point too far to the right.
Oh, interesting.
Yeah.
Or if you tried to walk towards something to your right, you might veer off course.
Exactly. This happens because the brain is sending extra nervous energy to try and move the eye right.
No.
And it uses that signal intensity to judge spatial location, even though the eye hasn't actually moved as much as the signal indicates. It's projecting based on effort, not actual position.
Wow. The brain's getting fooled by its own commands. Does that get better?
The source notes patients can learn to compensate for this over time, but it can be very disorienting initially.
I bet. An abnormal position of the head is a very common sign, especially a head turn or tilt.
Yes. The source explains patients instinctively adopt a position that moves their eyes away from the field of action of the weak muscle. This puts their eyes in a position where they can achieve single vision or at least minimize the diplopia.
So for our right lateral rectus palsy example, where looking right is difficult,
The patient will turn their face to the right.
Ah, okay. That keeps their eyes in left gaze relative to their head, where the right lateral rectus isn't needed as much, allowing them to look straight ahead at their target while avoiding the problematic gaze direction.
Precisely. And the source specifically discusses ocular torticollis for vertical muscle palsies, where patients often tilt their head.
Tilt, not just turn.
Right. And it's important to distinguish this from true torticollis caused by neck muscle issues. Ocular torticollis lacks the chin rotation and neck muscle contraction of true torticollis. It's particularly common with congenital or traumatic superior oblique, that's fourth nerve palsies.
Good distinction to make. Finally, vertigo is listed.
Yeah, the source attributes this to the combination of diplopia and false projection. It's worse when the patient is trying to use the affected muscle. Objects in the visual field might appear to jump or move.
That sounds awful. How do people cope?
Patients cope by adopting the compensatory head position or simply covering one eye.
Makes sense that it's less pronounced in congenital cases where the brain might suppress the image from the deviating eye or develop, abnormal sensory adaptations.
Right, like abnormal retinal correspondence.
But acquired diplopia can be incredibly debilitating initially.
Very distressing. And the source notes that over long periods, these paralytic squints can change. The opposing muscle to the weak one, the antagonist, can develop secondary contracture or tightening.
So the muscle that pulls the other way gets tight?
Yeah, and surrounding tissues like the conjunctiva and muscle sheaths can also tighten.
What does that do?
This physically restricts movement in the opposite direction and pulls the eye even further off center, sometimes making the originally incomitant deviation appear more constant, more like a comitant squint. The source references a flowchart showing this sequence of secondary changes.
So it can evolve over time. Okay, so having understood the signs and symptoms, how do professionals systematically diagnose these issues? What's the workup?
The source outlines two primary goals for the clinical workup. First, pinpointing exactly which muscles or nerves are affected, and second, investigating the underlying cause of the damage.
Right, the what and the why.
Exactly. This involves a detailed history, the standard eye exam, and potentially imaging like orbital ultrasound or CT/MRI scans, plus a neurological exam if a central cause is suspected.
Preliminary steps.
Preliminary steps include confirming the diplopia is binocular using the cover test if it's still there when one eye is covered. The problem is within that single eye, often refractive or, say, a cataract.
Okay, rule out monocular diplopia first.
Then, a careful observation of the range of movement for each eye individually and together.
And for milder weakness where movement limitation isn't obvious.
That's where more delicate tests are required, like the diplopia charting test. The source describes using red and green glasses in a dark room with a light source. The red filter is typically placed in front of the right eye, green in front of the left, separating the images seen by each eye.
Red-green glasses, okay. Like at the movies, but for diagnosis?
Sort of. The clinician moves the light in different gaze positions, often the 9 cardinal positions of gaze, and the patient reports the number, position, and characteristics of the lights they see. Is it one light or two? Where is the red light relative to the green? Is one tilted?
And this gets plotted on a chart.
Exactly. The chart captures whether there's single vision or diplopia in each gaze position, the horizontal and vertical distance between the images, any tilting, and whether the diplopia is homonymous or crossed. The source stresses noting the test distance and clarifying if the chart is the patient's view or the observer's view.
Seems like a really valuable tool.
It is. The diplopia chart is invaluable for diagnosis, documenting the baseline, and tracking changes over time. And the source notes that if you can get the patient to fixate with the affected eye, the resulting plot will show that greater separation of images due to secondary deviation.
Ah, linking back to that key concept.
Further confirming a paralytic issue.
Interpreting this chart requires skill, I imagine.
It does. You identify the false image. It's usually fainter, often tilted, and most importantly, it's farthest from the true image in the direction of action of the paralyzed muscle.
Farthest away in the direction of weakness. Okay.
You figure out which eye the false image belongs to by momentarily covering one eye.
And the point of maximal image separation is the critical piece of information.
Yes. That tells you the primary field of action of the weak muscle. For horizontal palsies, lateral or medial rectus, it's relatively straightforward. Image separating most to the right means a muscle that moves the eye right is weak. Image separating most to the left means a muscle moving the eye left is weak.
Makes sense. What about vertical palsies? They seem trickier.
They are more complex. You find the gaze position up, down, left up, right up, etc., where the vertical separation is greatest, then you determine which eye has the higher or lower image. The source reminds us to apply clinical reasoning and mnemonic devices to pinpoint the muscle based on which eye has the outer or lower higher image in that specific gaze position.
So it takes careful analysis. Are there limitations to these tests?
Yes, these subjective tests have limitations. As the source notes, they rely on patient cooperation and can be tricky with cognitive issues, long-standing contractures, or if a latent squint is unmasked.
Okay. Because vertical muscle palsies can be particularly challenging due to torsional effects and combined actions, the source details specific tests. The Park three-step test is a classic for isolating a single vertical paralytic muscle.
The Park three-step, how does that work?
Step 1. Observe which eye is higher in primary gaze. Let's say the right eye is higher or right hypertropia. This immediately narrows it down to 4 muscles that could cause this. The 2 depressors of the right eye, inferior rectus, superior oblique, or the 2 elevators of the left eye, superior rectus, inferior oblique.
Okay, narrows it down to 4 potential culprits.
Step 2. Determine if the vertical deviation is worse in right gaze or left gaze. The deviation will be larger when the eyes move into the field of action of the paralytic muscle's yoke, its partner in the other eye.
Testing the yoke muscles.
The source explains how this helps narrow down the possibilities based on which muscle's action is being tested more in right versus left gaze. So now maybe you're down to 2 muscles.
Okay, step 3.
Step 3. Tilt the patient's head to the right shoulder and then the left shoulder, observing the vertical deviation. This is the most specific step. The vertical deviation will increase when the head is tilted towards the side of the eye with the weakened muscle.
Towards the side of the weak muscle. Why does that happen?
The source explains the principle. Tilting the head causes reflex counter-rolling of the eyes, intorsion in the eye on the side of the tilt, extorsion in the other. To achieve this torsional movement, the brain activates the torsional muscles, obliques and vertical recti.
Right, the muscles that twist the eye.
If one of these muscles is weak, its synergist on the same eye has to work harder, and in doing so, its vertical action becomes more prominent. The side where the vertical deviation increases tells you which eye has the weak muscle, and combined with the first 2 steps, you can isolate it.
That's quite elegant, isolating 1 muscle out of the 12.
It really is. The Bielszewski head tilt test is essentially step 3 of the Park test and is particularly useful for diagnosing superior oblique palsies. The text gives the example of left superior oblique palsy causing left hypertropia that increases on left head tilt and decreases on right head tilt.
Okay, so the head tilt is a powerful tool.
To confirm the findings, the source reiterates that all the signs except the magnitude of the deviation itself, meaning the limitation of movement, the false projection, the increased diplopia, the larger secondary deviation, the head position, are greatest towards the side of the paralyzed muscle's action.
Got it. Consistent pattern.
For quantitative measurements, particularly useful for tracking progress or planning surgery, the source describes tests like the Hess screen and Lee's screen.
Hess screen. How does that work?
The Hess screen uses a tangent screen and red-green glasses. The patient sees red dots with one eye and uses a pointer with green threads to line them up, seeing the green threads with the other eye.
So one eye sees the target, the other sees the pointer.
Right. By having the patient align the green thread with red dots in various positions, you map the relative positions of the eyes when one eye is fixing. This generates a chart.
A visual map of the deviation.
Exactly. It permanently records the primary and secondary deviations and gives a measure of commitance. In a paralytic squint, the area plotted for the affected eye's movements is typically smaller or distorted compared to the normal eye, especially in the direction of the weakened muscle.
And the Lee's screen.
Similar concept. Using a mirror and illuminated targets in a haploscopic system, basically, it presents separate visual fields to each eye to plot their movements. Both provide objective, quantitative data essential for complex cases and, professional level assessment.
Okay, we've covered the general framework and diagnosis. Now let's look at some specific varieties of ocular paralysis, focusing on which nerve or muscle is affected, as detailed in the source.
Sounds good. Where do we start?
The source notes that when you have a palsy of just a single muscle, it's most commonly the lateral rectus 6th nerve or the superior oblique fifth nerve.
Why those two?
This is because their cranial nerves are relatively independent, traveling alone for much of their course. Palsies affecting multiple muscles are often due to problems with the third nerve, through nerve, as it innervates several muscles.
Oh, okay. More muscles, more likely a third nerve issue.
The text also defines terms like total ophthalmoplegia,
meaning everything is paralyzed.
All eye movement muscles plus pupil and accommodation paralyzed. External ophthalmoplegia is just the eye movement muscles, and internal ophthalmoplegia is just the intrinsic muscles controlling pupil and accommodation.
Useful terms. Okay, let's take the specific nerves. Sixth nerve.
Paralysis of the lateral rectus sixth nerve is one of the most frequent. The signs are esotropia, eye turned in, limited movement outwards, and that compensatory head turn with the face towards the side of the paralyzed muscle.
Face turned right for a right LR palsy.
Correct. The diplopia is homonymous when looking towards the side of the palsy. The source says the images are level and don't tilt horizontally, but might show a slight vertical tilt in up or down gaze due to the obliques. The images separate more the further the patient looks towards the paralyzed side.
Clear picture for sixth nerve. What about the fourth? Superior oblique.
Paralysis of the superior oblique foredown nerve results in the affected eye being higher than the other in primary gaze hypertropia. There's difficulty moving the eye downwards, especially when it's also turned inwards, adducted.
Down and in is the problem area.
Exactly. The characteristic head position is turned downwards and towards the sound side, often with a tilt of the head towards the sound shoulder.
Okay, tilt away from the bad eye.
Right. The diplopia is homonymous and is most noticeable when looking down, like when going downstairs. Patients really struggle with stairs.
I can imagine. What about the image?
The source notes the false image is seen lower than the true image, and its upper end is tilted towards the true image. This tilting is key.
Why the tilt?
The eye itself is slightly extorted, rotated outwards, because the superior oblique's intorting action is weak. This causes the image on the retina to be tilted, and therefore the brain projects it as if the object were tilted the other way towards the true image.
Fascinating interplay between eye rotation and image perception.
It is. The diplopia increases when looking down and towards the sound side, while the inclination of the false image increases when looking down towards the paralyzed side. Patients often report prominent vertigo, too.
And congenital cases.
Congenital cases often present with a long-standing compensatory head tilt, which, as we discussed, is the principle behind the Bilshowski test.
The source briefly mentions bilateral superior oblique palsy.
Yes, often caused by head trauma. This leads to diplopia due to both eyes being rotated outwards, cyclotropia, particularly in down gaze. It creates a V pattern, strabismus.
V pattern.
Mark convergence when looking down compared to relative divergence when looking up.
Why does that happen?
It's explained by the inferior rectus muscles, which pull the eyes down and in. When the superior obliques are weak, their adductive effect is unopposed in down gaze. The source mentions surgical relief for this cyclodiplopia often involves splitting and advancing the superior oblique tendon.
Okay. Now, the big one. Paralysis of the third nerve. Third nerve. That sounds complex.
It is the most involved as it innervates multiple muscles. The medial rectus, inward, superior rectus, up and in, inferior rectus, down and in, inferior oblique, up and out, the levator palpebrae, eyelid, and the intrinsic muscles of the pupil and accommodation.
Wow, controls a lot. What does a complete palsy look like?
A complete third nerve palsy causes a dramatic picture. The first thing you usually see is severe pitosis. The upper eyelid droops completely.
So the eye is closed.
Often, yes, which actually prevents diplopia by covering the eye. If you lift the lid, the eye is typically turned outwards, exotropia or divergent squint, and rotated inwards, intorted, due to the unopposed action of the lateral rectus nerve and superior oblique forward nerve.
Down and out, basically, but intorted.
Out and slightly down and intorted, yes. The pupil is usually large and doesn't react to light, and accommodation is paralyzed. The eye might also appear slightly pushed forward, proptosis, because the tone of the paralyzed muscles is gone.
And movement.
Severely limited upwards, inwards, and somewhat downwards. With the lid raised, there's prominent cross diplopia. The source describes the false image as higher and tilted, with its upper end tilting towards the paralyzed side. Again, the tilting.
Because the eye is intorted, the image is extorted.
Exactly.
Is there any way to check the other nerves if the third is completely out?
Yes, the source provides a neat clinical pearl for assessing if the fourth nerve is intact in a complete third nerve palsy. Ask the patient to attempt looking straight down.
But the third nerve controls downward movement via the inferior rectus.
Right, so the eye can't move down vertically. But the superior oblique, ivy nerve, is still working and will cause the eye to intort, rotating inwards as it tries to contribute to down gaze. You can see this by watching the movement of conjunctival blood vessels.
Clever trick. Are third nerve palsies always complete?
No, they're often incomplete, affecting only some of the muscles it supplies. This requires careful testing to determine the specific pattern of involvement.
Okay. The source then moves to congenital incomitant strabismus, noting these aren't always strictly paralysis, but can be due to developmental anomalies.
Right. Causes can include muscles being attached in the wrong place, absence or defects in the nerves themselves, like congenital double elevator palsy, where both muscles lifting the eye are weak.
Muscles missing or nerves not wired right.
Fibrosis or tightening of the muscle tissue from birth, congenital fibrosis,
Yeah.
or abnormal cross-wiring of nerves leading to muscles that's abnormal synergistic innervation, like in Duane syndrome, or even muscle absence.
The text mentions that minor congenital defects might appear more committed later in life due to adaptations, and it highlights the importance of achieving eye alignment before age 2, if possible.
Yes, that window is considered critical for developing binocular vision potential.
Musculofascial anomalies are discussed as specific congenital types. Duane retraction syndrome is a well-known example. What causes that?
The source suggests it could be due to fibrosis of the lateral rectus muscle, or more likely, an abnormal innervation pattern where the nerve fibers intended for the lateral rectus actually go to the medial rectus.
So the go sideways nerve goes to the go inwards muscle.
Essentially, yes, causing them to contract together, co-contraction, instead of reciprocally, one relaxing while the other contracts.
What does that look like?
In primary gaze, the eyes might look straight or show a slight inward turn. The hallmark signs are restricted or absent movement outwards, abduction. And when the patient tries to look inwards, adduction, the eye pulls back into the socket retraction and the eyelid fissure narrows.
Pulls back into the head. Wow.
And on attempted abduction, the eye might slightly protrude and the fissure widens.
How is Duane syndrome treated?
The surgical goals are typically functional, eliminating a bothersome head posture or deviation in primary gaze or cosmetic. The source prefers simple recession procedures, weakening muscles to avoid causing new vertical deviations.
Okay. Superior oblique sheath syndrome or Brown syndrome is another one mentioned?
Yes, that causes difficulty lifting the eye when it's turned inwards, when it's adducted. So it looks somewhat like an inferior oblique weakness, but it's actually a restriction.
Does it need treatment?
Often this condition is mild and doesn't need treatment, sometimes improving as the child grows. However, severe cases causing significant strabismus or potentially leading to amblyopia may require surgery targeting the superior oblique tendon, which is often tight or restricted.
So maybe cutting the tendon.
The source discusses tenectomy, cutting the tendon, as a possible treatment for a taut tendon, noting that post-operative superior oblique palsy might then need to be managed, perhaps by weakening other muscles.
Right. Always potential trade-offs. So what are the general principles for treating these complex conditions overall?
The source's first principle is always to address the underlying cause of the palsy, if identifiable and treatable. That's paramount.
Treat the cause first. Makes sense. What are the symptoms, like diplopia?
For the symptom of diplopia, prisms can sometimes help mild cases, but the source points out they are often impractical because the amount of deviation changes so much depending on gaze direction. A single prism won't work everywhere.
Ah, because it's incomitant.
Exactly. So surgery is the primary treatment for residual deviation and diplopia, but it's indicated only once the eye position is stable, usually after 6 months or so, to allow for any spontaneous recovery.
And what kind of surgery?
Common procedures mentioned include weakening the contralateral synergist muscle in the normal eye, the yoke muscle, or weakening the antagonist muscle in the affected eye.
So weakening other muscles to balance things out.
Often, yes. The source suggests performing these surgeries in stages to carefully assess the effects, referring to techniques discussed in the previous chapter.
Okay. The source also touches on other types of incomitant squints that aren't simply paralysis. Kinetic strabismus. What's that?
Kinetic strabismus is one category, described as aberrant or irregular eye movements caused by irritative lesions in the brain, like from meningitis or tumors in the brainstem or cerebellum.
Irritative, not paralytic.
Right. They are caused by irregular overaction or unequal stimulation, not weakness. They might happen during seizures or present with very inconsistent movements, which can help differentiate them from typical paralytic or comet squints, though it can be challenging.
Is there a more common cause of kinetic strabismus?
Yes, according to the source, the more common cause is spasmodic contracture or overaction of the antagonist muscle, often the inferior oblique. This frequently happens after a long-standing weakness of the superior rectus or superior oblique, particularly in congenital cases.
So weakness leads to overaction of the opponent.
It seems so. The typical presentation is a sudden upward and inward jerk of the eye when it moves into the field of action of the overacting inferior oblique, which is most prominent when the eye is turned inwards.
How's that treated?
Treatment involves weakening the overacting muscle, usually with a myectomy, removing part of the muscle, or recession, moving its attachment back.
Okay. Restrictive strabismus is another critical category of incomitant squint. These aren't due to nerve weakness or muscle paralysis in the classical sense.
Right. These are due to some mechanical restriction of eye movement, usually from local disease in the orbit.
Like what?
Causes include physically absent muscles, muscles that have become tight and fibrosed, like in severe dysthyroid eye disease, or myositis structural issues from trauma, like an orbital fracture trapping a muscle, or masses pushing on the eye or muscles.
So something physically blocking movement.
Exactly. Or abnormal innervation patterns like aberrant third nerve regeneration or Duane syndrome can also create a restrictive component due to co-contraction or inappropriate muscle activation.
How do you tell restrictive apart from paralytic? They both limit movement.
The source provides a key table distinguishing them. A major difference is the deviation in primary position in restrictive cases. The deviation might be surprisingly mild or even paradoxical, given the severe limitation of movement.
Okay. Are there specific tests?
Yes, two crucial tests are used to differentiate them at a professional level: the force duction test and the active force generation test.
Force duction.
The force duction test is performed with the eye anesthetized. The clinician physically attempts to move the eyeball using forceps. In a paralytic squint, the eye moves freely in the direction of the weak muscle. In a restrictive squint, the eye cannot be moved mechanically in the direction of the restriction test. This is a positive force duction test.
So you literally feel the restriction. What's the active force generation test?
This assesses the muscle's ability to generate pulling force. The patient is asked to try and look in the direction of the supposedly weak muscle, while the examiner resists the movement with their finger or a special instrument. In paralytic squint, there's little to no force generated. In restrictive squint, even though the eye can't move much, the muscle can still generate normal or near normal force against resistance. The muscle works, it just can't move the eye because something's blocking it.
That's a really clear difference. Does management differ?
Significantly. For restrictive squints, you generally avoid strengthening procedures like resections. The primary surgical approach is weakening or recessing the muscle that is causing the restriction. Sometimes you might also need to adjust the muscle in the other eye.
Weaken the tight muscle, not strengthen the weak one.
Exactly. The source warns results can be less predictable, and stage surgery with adjustable sutures is often preferred.
Finally, the source details fascinating examples of synkinesis, involuntary associated movements that happen when one movement triggers another unrelated movement.
Weird wiring, basically. Some are normal, right? Like the upper eyelid lifting slightly when you look up.
Correct. But pathological synkineses are often the result of abnormal nerve connections, either from birth or, more commonly, following injury and misdirected regrowth of nerve fibers, especially after damage to the third cranial nerve.
Misdirected regrowth, so the nerves go to the wrong places.
Precisely. The classic example the source gives is jaw-winking synkinesis, or Marcus Gunn phenomenon.
Jaw-winking.
It's typically a congenital issue where the upper eyelid on one side suddenly lifts a levator palpebrae spasm when the patient moves their jaw, like when chewing or talking. Often there's a slight teletosis otherwise.
Wow. Why the jaw?
The source links this to an abnormal connection involving the fifth cranial nerve, the trigeminal nerve, which controls jaw muscles. Severe cases might need surgery on the levator muscle.
Okay. What about other examples, especially after third nerve damage and that aberrant regeneration? Yes, instead of growing back to their original target muscles, the nerve fibers sprout and connect to the wrong muscles. This misdirection leads to specific telling signs that a professional masters to identify the issue.
Like what?
For instance, the Pseudo-von Greife lid sign. The upper eyelid retracts, it lifts up when the patient attempts to look down.
Lid goes up when looking down. That's backwards.
Exactly. This happens because nerve fibers meant for the inferior rectus, downward gaze muscle, have misdirected and now also supply the levator palpebrae, eyelid muscle.
Okay, what else?
Another is the pseudo-Argyll-Robertson pupil. The pupil reacts poorly, or not at all, to light, but it constricts normally when the patient focuses on something close, part of the near synkinesis.
Pupil doesn't react to light but constricts for near.
Right. This occurs because the pupil sphincter fibers are damaged, but some fibers intended for the ciliary muscle accommodation have rerouted to the pupil sphincter.
More crossed wires. Any others?
You can also see horizontal gaze lid dyskinesis. The upper lid retracts on attempted adduction, looking inwards, and falls on attempted abduction, looking outwards.
Lynn moves with side-to-side gaze.
Yeah, due to medial rectus fibers crossing to the levator. There's also generalized difficulty with vertical gaze and sometimes adduction on attempted vertical gaze.
Looking up makes the eye turn in.
Where trying to look up or down causes the eye to pull inwards as well if vertical rectus fibers misdirect to the medial rectus.
And one more.
And a monocular optokinetic response.
Yeah.
The affected eye lacks the normal jerky eye movements, nystagmus, that happen when you look at vertical stripes moving across your field of vision while the normal eye shows them.
So a whole constellation of signs indicating aberrant regeneration.
Exactly.
Yeah.
Recognizing these patterns is key to diagnosing the underlying third nerve issue and its history.
So bringing it all back, as the source does in summary, Incomitant Strabismus is characterized by deviation that changes with gaze direction, resulting from a localized problem in the oculomotor system.
And these problems can be neurogenic paralytic, affecting nerves, or nuclei myogenic diseases, primarily of the muscle itself, like myasthenia gravis or myositis,
Right.
mechanical restrictive fibrosis, structural issues, entrapment, or a combination of these.
The text highlights examples we've covered. Myasthenia gravis, dysthyroid eye disease, myositis, orbital fractures causing muscle entrapment, space-occupying lesions, and those important congenital musculofascial syndromes like Duane retraction syndrome and Brown syndrome.
A really wide range of underlying causes leading to this specific type of eye misalignment.
Wow. We've really taken a deep dive, following the intricate paths laid out in PARSONs, exploring the causes, tracking the symptoms, understanding the tests professionals use, and differentiating the various types of incomitant squints, including the fascinating world of synkinesis.
Yeah, the level of detail required to truly understand these conditions, to differentiate a nuclear lesion from a nerve lesion from a restrictive process, or to interpret a complex diplopia chart is immense. Hopefully, this comprehensive exploration has moved you significantly closer to that level of detailed understanding that defines mastery in this field.
As we've delved into the complex mechanics and nerve pathways that govern our vision, we've seen how vulnerable this system is to disruption, leading to symptoms like double vision and false perception that fundamentally alter a person's reality. But beyond the pathology, doesn't the sheer level of classification and detailed observation found in texts like Parsons speak volumes about the history of clinical medicine itself? The dedication required over generations to meticulously document and understand these intricate biological systems, one symptom, one test, one syndrome at a time. Something to ponder as you look at the world around you.